backup server, it says. Do I know it is recording? Where is the recording sign? Signals would come, isn't it? Yeah, I think there is a small red signal there.
It started, sir. It started.
Yeah. Okay, let's start.
Okay.
Okay. My voice is clear?
Yes, sir. Clear,
Yeah.
sir.
Okay, thank you. Thank you. I'll carry on. Any problem on my side, please interrupt and tell me if any voice or the video. Yeah, keep an eye on every 10-15 minutes if you're not.
Let me know, sir.
Good morning, students. I think today we are, as you can see, module 23. The next few modules are going to be really very important as we are going and the last leg of our journey towards getting this surgery topics all covered in well in time. I think module 23 today and probably 24 next week are going to be on short cases. And 25, 26, I'm planning to have some important long cases. Then the last two classes, probably some instruments, suturing, and some key subjects, what as an undergraduate you should know as a broad-based surgical concepts before you appear for Viva or even an examination. So as we go this speed, probably by December 15th, we'll be finishing all the 30 modules. So I wish you all from bottom of my heart a happy Puja, wishes Saraswati Puja today. And I'm sure with the blessings from Lord Saraswati and Durga, you all read coming with the flying colors in your own field, chosen field. So let us concentrate in the next hour or so with the top 10 short cases in surgery. Next week, I'll put some more short cases, which are not as frequently shown, but sometimes if the cases are available, you never know, they can keep all those cases, so you should prepare. A patient with, for example, ileostomy or a malignant melanomas, things like that also can be kept if they are coming. But believe it from me, the cases I'm going to show today, out of the 10, at least 2 cases you will get definitely, most of you. I mean, on average, I presume like a smarter or a short case, you're expected to see, at least in those days, we used to have at least 3 cases on average. So at least 1 or 2 cases from today. So let us have a clarity in our understanding in this common 10 cases for the next 60 to 70 minutes or so. Okay, with that little introduction, let me go like what we normally do. I'm going to throw here 10 important cases. I'm going to examine myself, giving you the diagnosis, then how to approach the diagnosis. I'll tell you the way I see as a student, but I probably will ask you randomly. Feel free to interact or add so that it will give weightage to the discussion today. If I am asking anybody, if you're not able to give an answer, don't worry. You just keep quiet. I'll continue. I'm not going to put the question to somebody else. So I'm going to ask you or give you a chance. If you're happy, then it's fine with me. Okay. So that's about the first one. The second thing is when you see a short case, what you are expected to and how you are expected to tell. That is a template. We'll have some template. I'll tell you in the next couple of subsequent slides. And I'll tell you the key things what as a surgeon we like to ask you in the examination when a short cases comes. You mentally prepare, rehearse yourself for those things. You think and act like a surgeon, then you will get there without much problem. Okay. See, for example, most of the short cases, as you can see, are going to be only about 3 to 5 minutes. Go and see that patient, 1 or 2 cases that come back quickly, present that case. So when you go, you may not be the first student or a doctor to see that patient, but still it is always as a courtesy. If not in our setup, at least in abroad, that's what they want. You introduce yourself to the patient. You tell what's you are and what is the purpose. You thank the patient for cooperating with you. Like that, you get the patient's rapport first. So introduce to the patient yourself. Very important in a broad examination, but here we don't give importance. You just go, take it for a granted patient has already given you the consent to feel here and touch here and examine, but it is not. You should get what we call implied consent form. Okay. Next is a key questions, very important. For example, if you see a patient with a swelling in the forehead, then you go and ask what's her age, occupation, and how long the swelling was there and how it progressed. These are all the key questions, because when I'm asking you to present the case, you have to tell me this is a 30-year-old lady, post woman by occupation, presenting with a 7 months history of swelling in the forehead, gradually increasing in size. And now come for further investigation and treatment, sir. Like that, you start. The first line should be very clear. That is patient specific description is the first line of your thing. Next important thing, of course, is the second part. This is very important for postgraduates, but even for you or for anybody for that matter, it is always a habit to know. It is not enough to know what patient has come with, what patient also is having or had before, like a important background medical history. See, for example, management of a problem in a diabetic patient, ischemic heart disease, renal disease, hypertension, they may slightly differ. And also if the patient is on certain drugs, very important. Like for example, if I say this patient is a known case of ischemic heart disease with a valvular replacement, is now taking, sir, warfarin. What is warfarin? It is a blood thinner. And this patient is having a possibly, for example, large lipoma. Then examiner will ask you, what will you do for this patient, doctor? Sir, this patient needs a excision of the lipoma because it is symptomatic, but because the patient is on warfarin, I have to stop the patient taking warfarin for a few days, check the patient's INR, and if the INR is less than 1.5, then I'll take the patient for surgery perioperatively, that is within few hours after surgery. I put the patient on low molecular heparin until such time when it is convenient to restart the patient back on warfarin. And during the whole process of surgery and the change of drugs, I'll be in a constant consultation with a cardiologist who originally prescribed the warfarin. So this is the way to safely, see, this is what we important, is a clinical management. So you need to see the patient as a whole, don't just look at the swelling and tell lipoma excisions are. Then will you do excision in this patient? I will ask you. Because that particular patient is ischemic heart disease, that particular patient is on warfarin. So he expected you to give that answer, and he wanted you to be different, confident, practical, get to the point, relevant to the patient. That is what important. Okay. So that's why the importance of background, medical history, and the medication. Okay. Just keep admitting all the people here. Let me. Coming to the next important thing is you start examining. Like any other examination here, even though it is a short case, how long it takes to get the findings in a short case. Say, for example, a basis cyst or a dermoid cyst, 2 minutes. So 2 minutes for your examination, 2 minutes for your history, and 1 minute to mentally rehearse whatever points. And if you're not able to recollect, have a little paper and scribble and keep it in your packet. There is no need to write and submit it to the examiner like a long case, but still you might forget. So if you are having that problem, then you can always have a little scribble for you. But main thing is mentally rehearse how you are going to speak for the next 1 minute, because the first 1 or 2 minutes, your conversation with the examiner gives the examiner the impression, here is a student who has presented several such cases before. He is systematic. He is confident. He seems to be able to get the information from the patient comprehensively, collectively, concerning with the management of this problem. Like that he should be. So he can be a very good CRRI quality. So we can give him a pass. Like that the examiner should give you, get the confidence on you. So all these things are possible only by These 5 important steps. So get to know the patient, get to know about the key symptoms and about the patient specifics, and that background history, medication, examine generally patient is anemic, all those things, and specific to the case that are we are going to come. Okay. Coming to the next important thing is how you are going to impress me. See, for example, now you have examined the patient. You are now coming to sit in front of me as a student. Okay, doctor, let's see what you have got in this patient. Present this case, they'll ask you. Then you need to just go without stoppage. Don't hesitate. Hesitation is an enemy for you. And it is like what I call a taxi meter. You are given only 2 minutes. Silence kill your time. Don't have silences in your presentation. You keep going. Don't expect the patient, the doctor or the surgeon to say, okay, next. He will not say. He'll just, at least if I am the examiner, I'll just simply sit quiet and see how confident and how cohesive your presentation. So you summarize your clinical finding. Sir, this is a 35-year-old lady, post-human, presenting with a 7 months history of swelling in the forehead. On clinical examination, she has a 3 centimeter swelling over the forehead above the right eye. It is soft in consistency, non-tender, mobile. Skin over the swelling is normal, and fluctuation is present. Transillumination absent. There is no regional lymph nodes. What's your diagnosis, doctor? My first diagnosis for this patient is when you say first diagnosis or main diagnosis, key diagnosis, then obviously examiner was going to ask you different diagnosis. That's the safer way of telling. Then it says a basis is. Then what other diagnosis can you offer? The differential diagnosis, at least he should give you 3. That is a dictum. 1 plus 3. If you give 4, most of the time, even if your diagnosis is wrong, if your original diagnosis is within these 3 differential diagnoses you offered in undergraduate, you usually get passed. Okay, so don't worry about that. So that's why the differential diagnosis is important. But whatever diagnosis you utter, the one important thing is substantiate your answer. Why do you say so? Why you think it is a sebaceous cyst, doctor? Because to say it is a sebaceous cyst, you know all by this time, the most important thing, it is a subcutaneous swelling. It should have punctum. If the punctum is present, sebaceous cyst, no other diagnosis. But if the punctum is absent, still it could be sebaceous cyst, but it can be something else also, like a dermoid. So you have to tell why you say so. And investigation. Usually most of the short cases, hardly we do any investigation, but if they are like FNAC or X-ray of that region, please tell. Then tell the treatment. But when you treatment, there are 2 ways you tell the treatment. One, overall, sebaceous cyst as such, this is the treatment. But for the sebaceous cyst, in this 37-year-old post-human, what is the treatment? So specific to the patient, what is the treatment you are doing? You can tell, sir, this patient, I explained to her, it is a very small cyst. She is only concerned about the cosmetic consequences. I told her, when I exercise is going to leave a scar. So she decided to leave it for a few weeks, then come back. Like that, there may be some reasons for delaying the treatment or asking for a medical treatment or alternative. See, so you need to take the patient into discussion when it comes to treatment availability, because there are more than one modality of treatment nowadays. So that is what we call informed consent. Last about this, they can ask you a background history, all about sebaceous cyst, dermoid cyst, rodent ulcer, like that. Whatever case you are given, they might ask you any random question. So you should be prepared. So this is in essence the questions going to be asked for you in all short cases. So mentally prepare for them. Then you start having case after case, practice with your your colleagues, and you become a master of this short case scenarios. Okay. With that mini introduction, let us go 10 cases non-stop now. Here is a 50-year-old gentleman presented to me with a swelling on the left shoulder for nearly 7 months. Now the last 2 months it's been painful. On there is a known diabetic, he is on oral anti-hypoglycemics, otherwise he is fit and healthy, and he is a driver by occupation. Okay, that's about the history background. I got it. Now what is the finding here? Let us try somebody here. Can we ask Dinesh Kumar? Do you like to see and describe, try to describe, unmute yourself if it is possible. Let me see whether I can unmute.
Sir?
Yes, Dinesh, I can hear you.
The swelling is present in the back of the patient, sir.
Yes.
It is of size of about 5 centimeter into 6 centimeter.
Yes.
Surface is pigmented, sir.
Okay. Anything else? So it is only inspection you can tell. You can't palpate from wherever you are. Anyhow, I'll tell you. So here there is a 5 centimeter swelling over the left shoulder region, just in the left suprascapular region, and with the skin over the swelling is stretched and shiny. That is actually shiny skin. There is no undue dilated veins, no scarring. Okay, and on palpation, it is not warm, it is not tender, it is soft, fluctuant, and it is transillumination negative. On mobility, it is mobile on the surface, but the skin is not pinchable. I could not see any obvious punctum. So this is the finding. And there is what is going to be the thing. So rest of the swelling, I mean, body is examined. In addition, he was also found to have a small swelling over the D3 at the midline. If you see here, there is another small swelling. Can you see here, Dinesh? So he said, when I asked him, what about this swelling? He said, sir, this particular swelling, what you are seeing, also started like that about a few months ago, only it attained this length. So obviously what was like this one only came this size. So this is an index lesion, it will give a clue. And there, if you see, there is actually a small punctum, there are small cysts also developing. So he is a case of a classical case of a cystic lesion of this description. For all practical purposes, cyst, subcutaneous skin cyst is an epidermoid cyst or a sebaceous cyst, unless proved otherwise. If there is a punctum is present, 100% it is sebaceous cyst. If the punctum is absent, 90% it is sebaceous cyst. Okay, so this is a sebaceous cyst. This is another sebaceous cyst over the right earlobe. Okay, you can see a large 4 centimeter. Okay, just in between the right ear and also the temple region with the skin stretched. And here also, if you can see, there is a skin over the swelling is normal, no obvious punctum. But what is important is moldability, very important sign of sebaceous cyst. Even though it is cystic, if you just press it and leave it, it will have what we call a pillow signs or a moldability. Just you keep it like press it, it remains like that. It won't spring back to its cylindrical shape like a hemangioma or a fluid-filled lymph cyst. So it will not refill as you take out the finger. So it is cystic in nature, moldability present, because the material inside the sebaceous gland or a cyst, you know, it is not a cyst fluid, it is more of a pultaceous. It is a thick, like a cheesy material, okay, semi-solid. It is neither solid nor liquid. So because of that, it is moldable nature. So that's about the, so they'll ask you immediately, okay, why you say so? I told you already. But what is a sebaceous cyst, doctor? Then you need to know it. It is a retention cyst of a sebaceous gland. So sebaceous gland is present wherever there is a hair follicles. So whenever there is a big sebaceous gland cyst with a material made up of keratin, sebum, dead cells like this, when you press, there is a whitish pultaceous material will come, sometimes yellowish white color. And super infection causes some foul smelling. But one of the common infection is by this mite, okay, the dermal mite called a Demodex folliculorum. And it starts, usually it is primarily a skin cyst, intradermal, because it is the epidermis and dermis. It is an epidermal cyst. okay, within the layers of epidermis. So that's why it is called intradermal cyst. But it sometimes it is very big, it extends into the subcutaneous plane. Punctum is present in 50%. Paucity of the hair, because it keeps on enlarging, there is a little bit of hair loss, apparent hair loss will be present on the summit. See, for example, if you have a sebaceous cyst on the scalp, compared to the rest of the area, that area will have lack of hair. That is another classical thing. Unlike a dermoid cyst or a lipoma or other swelling, the loss of hair, paucity of the hair, punctum, and the moldability are classical signs of epidermoid cyst. The common cyst sites, I told you up here, imagine above the nipple level, where in the trunk, neck, face, or scalp. Anywhere here, it is quite common. And in male, it is scrotum also. In women, also around the vulva, vagina, but male, very important is the scrotum. Multiple scrotal sebaceous cyst. You will sometimes see, but never present. Very, very important question I'll ask you. Where you don't see sebaceous cyst, doctor, you sow palm and sole, because there is no hair follicles. So palm and sole definitely, and also vast majority of us will not develop, even though there are some hair, but not much in the dorsum of the foot. Okay, so that's foot as such and palm. Very important. So this is a very typical sebaceous cyst in the scrotum. That's why we can't keep on excising individually. Scrotal skin excision. We excise the whole scrotum, the scrotal skin reconstructed. Is one of the common problem you encounter as a surgeon in the beginning of your career. Okay. So these are all the classical findings. Why you say so? It is a sebaceous cyst. Exam will ask you. You have to tell it is cystic swelling, skin attached at the summit, skin is not pinchable sometimes, whatever way you say. Punctum is seen, sir. If it is present, you tell. Molding sign is positive. If it is present, you tell. But if it is a super infection like chronic abscess, molding sign may not be present. It is transillumination negative. So they'll ask you, tell me 3 cystic swelling where transillumination is positive, 3 cystic swelling where transillumination is negative. Dinesh, would you like to try again? Tell me, there are some cystic swelling, but when you do the transillumination test, the transillumination is negative. One, of course, is a sebaceous cyst. Anything else you can think of?
I don't know, sir.
Dermoid cyst is again another one. Branchial cyst is the next cyst. All the 3 cysts, because of the nature of the content inside, they all transillumination negative. The only cyst which is having a clear fluid, watery fluid, which will be brilliantly transluminant, is a lymph cyst or a cystic hygroma. Or if you have a primary hydrocele. In the hydrocele, there are 2 types of hydrocele. Okay, one secondary to infection of the testis or the epididymis, that is secondary hydrocele, where the fluid will be cloudy, so transformation test is negative. Whereas a primary hydrocele is of idiopathic origin, where the fluid is straw colored. Okay, then it will be brilliantly, or epididymal cyst for that matter, clear fluid. So they will be brilliantly epididymal cyst, hydrocele, lymph cyst, and then cystic hygroma. These are the 4 classical example for transillumination test positive. Okay, that's about the clinical finding. And they'll ask you, whenever you utter a diagnosis, a differential diagnosis, always have them. Any subcutaneous skin swelling, you tell, sir, differential diagnosis lipoma, dermoid cyst, neurofibroma, chronic abscess. 4, keep it all these. For lipoma, you tell sebaceous cyst, dermoid cyst, neuro, like that. For neurofibroma, you tell the other 4. So these 5, like a group, if you tell one as a diagnosis, the other 4 you tell them as a differential diagnosis. Very simple, okay? Because these are the 5 common subcutaneous swelling we see in the human being, okay? But you can always tell why you think it is a sebaceous cyst as first place. As you can see, punctum. You can see clearly here, close-up view of a sebaceous cyst. Right, the summit of the swelling, you see a small punctum, and if you squeeze the swelling, sometimes you see that yellow is white. The pultaceous material will be coming like a toothpaste coming out. Okay, very, very important. Why we operate on sebaceous cyst, or what are the problems if you don't handle the sebaceous cyst? They'll ask you. Risk of infection, sebaceous horn, Cox peculiar tumor, rarely, very rarely, sebaceous adenoma or carcinoma. So sebaceous cyst also can be 1 in a million. I yet to see a case of carcinoma coming from sebaceous cyst, but at least in the books they do describe. So, but what is more important is infection. Usually diabetic people, like the patient I told you, they can get super infection. What was a Baltani's molding sign will be absent. Now it will be truly cystic and it will be tender now. Presence of tenderness, presence of the skin changes like this, with this purulent skin, they're all, see, you can see also punctum is shifted at the periphery, usually they submit. They're all signs of infection. And the second important thing is sebaceous horn. So the material coming out, the pultaceous material, say sebum, they get dried up, like becomes like a horn. I'm sure in Hamilton Bailey you see a big lady with a horn like that. So that is another interesting observation. The third is even rarer would be Cox peculiar tumor. What is Cox peculiar tumor? It is not a tumor, it is a misnomer. Cox peculiar tumor is whenever you have a sebaceous cyst over the scalp, which ulcerates, it leaves you with this lesion, which is appearing like a squamous cell carcinoma. But unlike squamous cell carcinoma, this is not indurated. There is no everted rolled out edges. There are two classical findings in squamous cell carcinoma. One is induration. It feels hard, but this one will feel soft, firm at the maximum. Second, here it is raised, but not everted like a cauliflower rolled out margin. So rolled out margins are absent, and it is very typical in the. So what you do here, if you want to confirm, you can always do a bench biopsy. After that, if it comes as a benign, then by an elliptical incision, you can remove and cover this area with some flap cover, rotational flap cover. So whenever you remove a large lesion, they'll ask you, how can you close this defect? Sir, the defect anywhere in the skin can be closed by two ways. One, by putting a graft, taking a skin from one more part, that is a donor, to this area, there is a recipient, skin graft. There is a partial thickness skin graft, there is split thickness skin graft, or a full thickness skin graft, usually split thickness. But what is much more easier and also cosmetically acceptable is a rotational flap. So that is a different thing that when you are going to do MCH plastic surgery, you'll see. So you have a 5 centimeter defect, they make a big incision like this, then they rotate the whole scalp skin, okay, because of the mobility, and they'll put stitch. So it is possible to adjust the skin in the scalp because of the high vascularity, rotate okay, in such a way, and then it will become again a normal skin, hair bearing skin. That is cosmetically very good operation. Okay, that's about the next. And these are, but if you don't remove the capsule completely, high chance of recurrence. So recurrence of sebaceous cyst is due to what? They'll ask you, because of incomplete excision of the capsule. So what you should do treatment? The treatment is by under local anesthesia. We have to make an elliptical incision, excise the whole lesion along with all the capsules. This is called an extracapsular incision or excision. There are two types of operation for benign pathology. One is an intracapsular, another is an extracapsule. Because what is extracapsule? Imagine it is like a bag. It is containing sebaceous material. So you remove the whole bag like that. That is extracapsular. That is, you remove the whole sebaceous cyst like a bag. Second is intracapsular. There you open the bag, only the content is removed. That is intracapsular. What is a classical example? Lipoma. Next important thing is fibroadenoma. So fibroadenoma, lipoma, you don't, why? What is the advantage of intracapsular excision? Bleeding is literally very little. Whereas extracapsular can happen bleeding, but provided we just closely, if you excise very close to the capsule, very easily can be done with very little loss of blood. Okay, so that's all about sebaceous cyst, you know. Next, we'll move on to the next case. This is the patient, a 30-year-old boy actually came with 2 years history of swelling over his right elbow region. So what you see is here, no comorbidity, he's not on any drugs, he's a manual laborer, but he is getting married, so he's worried about this swelling. And also somebody said, I mean, it might become something nasty like a cancer. So he obviously came to us. So what is the finding? What is the likely diagnosis we can offer? Gautam Prakash, would you like to try? Gautam, introduce yourself, where you're from. Would you like to describe the swelling, inspection finding? It is over the right elbow region. Unmute yourself if possible. Sihana, would you like to try? Let me just carry on. This is actually a 3 centimeter swelling over the right extensor aspect of the right forearm, about 3 centimeter from the elbow. And it is skin over the swelling is normal. There is no dilated veins. There is no scar. There is no punctum. The skin is easily, freely, it is not, skin is not attached, and the swelling is freely moved in both direction. And putting the muscle into contraction, there is no adhesions or fixity, and it's soft, and there is a degree of fluctuation with a slippery margin, and I could feel some lobulations. Okay, so these are all the features suggesting it could be what we call a lipoma, a classical commonest swellings in the subcutaneous region. So first is a sebaceous cyst, second is a lipoma. Take it from me, these are the two common swelling we do see day in and day out, and most of the time they come for surgery. And this is another typical location and presentation of a supraclavicular lipoma. You can see a like a hemispherical swelling over the right shoulder, 6 centimeter into 5 centimeter with a normal stretched out skin. And there is no, see, whenever you have over this region, always you tell two more findings. One, impulse on coughing. Okay, because impulse on coughing, because whether it is having a communication with the thoracic cavity. Second, if the same swelling, if it is somewhere here, very close to the great vessels, then you have to tell it is not pulsatile, or there is no visible pulsations. So accordingly, you are trying to, give the examiner the impression, I am thinking about vascular origin, I am just thinking about intrathoracic origin. So very, very important is relevant to the site, you keep adding additional findings. So I will say probably there is no impulse on coughing, there is no pulsation. That palpation, of course, it is like other swelling. It is non-tender, soft, pseudo fluctuation, slippery margin, no fixity, and it is lipoma unless proved otherwise. So this is the classical finding of a lipoma. Why do you say so? Immediately they'll ask you. You should have all the answers ready in your hand. That's why mentally rehearse for that. Offer the differential diagnosis. I told you, one of the commonest differential diagnoses for lipoma, especially in the forearm, is a neurofibroma. The neurofibroma is much firmer, lipoma is soft. Both are mobile, but neurofibroma, the mobility is more in one direction, less in the other direction. Which direction it is more? That is along the nerve, it will less mobile. Across this nerve, it will be more mobile. So it will be, for example, it will be moved this way better, this way it will be less. So it's all. So movement is restricted in one direction, neurofibroma. And also there will be usually, there will be tenderness on feeling, and then paresthesia along the distribution of the nerve. These are all the additional features to suggest what you're dealing with is a case of a neurofibroma rather than a lipoma. And of course, sebaceous cyst, dermoid cyst. And if the same lipoma is somewhere here, for example, then this is a typical site of a lymph node, typical sites of the lymph node, and the typical sites of a lymph node in the neck. So you have to think lymph nodal pathology. So if any swelling, especially lipoma, is in the region where you expect nodal lymph nodes present, say it can be a tuberculous adenoma or lymphadenopathy, sir. Then they'll ask you, what are the different causes for lymphadenopathy, doctor? Non-specific lymphadenitis, tuberculous lymphadenitis, lymphoma, then secondaries. See this like that. In lymphoma, Hodgkin's, non-Hodgkin's. Like that, you have to keep telling the examiner without any hesitation. Then the examiner knows here is a confident guy or a girl able to address the question immediately without a matter of hesitancy. That is the best way to fetch your mark and walk through the exam. Investigation. I told you already, we don't do much investigation for most of the short cases, but still now exam and also for practice we do for the patient satisfaction or confirmation. Some ultrasound, for example, will clearly say there is an hypoechoic lesion there. Lipoma, hyperechoic lesion. Lipoma usually is a fat is a increased, so hyperechoic lesion will be seen. Okay. Treatment. If the patient is worried or symptomatic, yes, we operate. If they are multiple lipoma, painless, then you can always tell the patient wait and watch policy. But excision is always under local anesthesia, and they'll ask you some background histology. What is a lipoma, doctor? It is a benign tumor. What is a malignant equivalent? It is a liposarcoma. So it is a benign capsulated tumor of the mature lipocytes. Commonest site is underneath the skin, but other sites can be, it is a ubiquitous. What is means? It can be present anywhere in our body, like subfacial. That is here also in the palm and sole. It can be deep to the palmar and plantar fascia, or also in the scalp, also deep to the fascia. Intramuscular, retroperitoneal, intra-articular or subsynovial, submucosal, very, very important, especially small bowel lipoma. They acts like a lead point leading into small bowel intersusception, very important. Rarely it can be also subserous and even extradural tumor. So it is everywhere. You should tell the examiner. That is the importance of lipoma. The lipoma, why we, most of the time, the cosmosis is the reason why people are worried, especially in the forearm, exposed area. If you're wearing a half sleeve, you're worried. And the pressure effect, rare, it can happen. Okay. Traumatic fat necrosis. If you have a large lipoma, if it gets injured because of the fall, the fat goes for necrosis, then it goes for saponification, then later even for calcification. So sometimes you see an X-ray, there will be calcified deposit within the lipoma. Rarely only it gets infected or abscess formation. Whenever there is an abscess in the lipoma, it is usually secondary to fat necrosis. It is not an abscess as it is. And you have to tell the examiner, one area where a lipoma becomes liposarcoma is retroperitoneum. And another area is any proximal areas, proximal thigh, proximal or close proximity to the shoulder. So shoulder joint, hip joint, around the region, if you see a lipoma, they are by tradition known to become a liposarcoma at a later age group. So better you treat them well. And those cases where you suspect liposarcoma, in addition to ultrasound, one more investigation what we do, MRI. So very, very important investigation, take it from me. Any soft tissue tumor larger than 5 centimeter, you suspect sarcoma, you have to do an important examination in addition to the ultrasound. Whatever you do is MRI of that area. So it will give you clearly the local vascular and also local muscular invasion very easily. Treatment. Lipoma, how we treat? Unlike sebaceous cyst, where the extra capsule, that is sebaceous cyst, you remove with the capsule. Lipoma, you leave the capsule, only remove the fat. Okay. Or you can sometimes do what we call a liposuction. What is a liposuction? If there's a lipoma here, you just take a small hollow bore needle and you go several times like this. Okay. When you do that, and then you apply suction in the needle, so it will suck. So the solid lipoma become a liquefied because of this frequent passage of the needle vibration. Then you keep sucking those. So through a small tiny hole, you are able to suck the whole the fatty deposits. Okay, that is a liposuction. Nowadays, the treatment of choice for gynecomastia, fibroadenoma, or even lipoma is this one. Okay. See, this is what we normally do. We make a skin crease incision. Don't say what incision they'll ask you here, because when you make an incision, the incision should heal with a less perceptible scar. Very important. The scar should not be ugly, should not be very easily visible. So you have to imagine your face as if you are an 8-year-old boy, lady, or a old man. So you can see the wrinkles. Here in the forehead, the wrinkles will be more horizontal. Here will be like this, perioral like this, and here and there around the eye. So imagine that that is what we call a Langer's line. Langer's line is the least resistant skin lines. So if you make an incision along the Langer's line or along the skin creases, usually the scar will be less perceptible. That's why we always say a small skin crease incision made under local anesthesia. You give a squeeze by cutting the capsule, it just pops out. The lipoma pops out, we say. Here is a lipoma. This is pops out like this. And you send it for histology if you are interested. Some rare question they'll ask you. If you've really done well, they'll ask you, what is Dergam's disease? It is a multiple lipomatosis or adiposis dolorosa, painful lipoma. Mad lung disease. Mad lung disease is if you have a lipomated deposit, the whole neck will be diffusely like a bull neck. It will be diffuse lipomatous deposits around the neck, especially in a chronic alcoholic liver disease patient. Then Singewald syndrome is nothing but if you have a sacroiliac joint on the back and both sacroiliac joint, sometimes you can have a deposit, fibrolipomatous deposits. That is called Singewald syndrome. But what is more important for me, actually, we see every other day is lipoma in the spermatic cord when we are operating a case of inguinal hernia. So lipoma of the cord, one of the differential diagnoses for inguinal hernia. Next is when you have a swelling in the axilla in the women, there are two different diagnoses. One, it could be a lipoma there. Second is it could be an accessory breast tissue. How will you differentiate? Accessory breast tissue will undergo menstrual changes. In other words, patient will say during the menstruation cycle, she'll have some pain or swelling or tenseness of the swelling, whereas those menstrual related changes will be absent if it is a lipoma. So this is the one way of differentiating accessory breast tissue and a lipoma. But both needs excision for cosmetic reason. This is a typical Dergam's disease. You can see 1, 2, 3, 4, 5, 6, 7, 8 lipoma. Here you can see even 15, 20 lipomas. You have to reassure this patient. Nothing need to be done. Most of the times they have to come for a regular 3-monthly follow-up. That's all. Okay. The third important condition you will be seeing as an undergraduate is, here is a 30-year-old manual laborer came to us with a swelling in his forearm for at least 2 years, and it is very painful lately, so he is concerned. So when we examine, as you can see, there is a 3 centimeter swelling in the volar aspect or flexor or anterior aspect, whichever. Usually it is a volar. This is the dorsal or extensor aspect and a flexor aspect. Okay, and this swelling is tender, firm in consistency. The mobility is more on this direction, less on this direction. Okay, this is very, very typical. And on pressing this, patient has a tingling sensation in the distal region. And this is very typical of the firmness, the restricted mobility in one direction, the location, skin over the swelling is normal, classical of neurofibroma. So subcutaneous firm swelling, neurofibroma. Subcutaneous soft swelling, lipoma. Subcutaneous cystic swelling, it is dermoid cyst or sebaceous cyst, like that you have to have. And second, I said restricted mobility, okay, across its axis. There is more across its axis, less along its axis. This is very important. Paresthesia to pressure on the swelling. Sometimes neurofibroma, if it's involving the eighth nerve, acoustic neuroma. It can cause additional neurological deficit. Or rarely you can have the neurofibroma involving the dorsal roots of the spinal cord. Then what will happen? You'll have a tumor both inside the spinal cord and extending through the foramina outside the spinal cord. That is called a dumbbell tumor. Dumbbell tumor is like that. One component inside the spinal cord column, another outside with a small neck inside. That is like a dumbbell. So dumbbell tumor is very, very classical in a neurofibroma. Differential diagnosis, I told you already. Okay. Right. Anything else they'll ask you as far as the pathology? What is neurofibroma? We know lipoma is a benign capsulated tumor of mature lipocytes. So you have to go back, okay, tomorrow, read all these things definition wise, because every short case, there are one or two bullet points they'll ask the examiner, especially for people, senior examiners, very fond of these definitions. Define an ulcer. What is epidermoid cyst? Like that, you have to tell clearly. Embryological basis, everything, if it is a dermoid cyst, thing like that. Coming to the neurofibroma, it is a benign tumor of the nerve sheath, the myelin sheath. Each axon is covered by a sheath. That there are two types of sheath. Okay, perineurium, endoneurium. Neurofibroma arises from the endoneurium, that is each axons, whereas perineurium, the whole nerve, mixed nerve is the whole outside. So neurolemoma or schwannoma is one type of neural tumor. Another is a neurofibroma. There are so two benign tumors. One is a schwannoma, another is a neurofibroma. The neurofibroma itself can be solitary or multiple. Multiple neurofibromatosis is otherwise called von Recklinghausen's disease. This is one of the extreme cases of von Recklinghausen disease. With the multiple neurofibromatosis, okay, you can see pedunculated neurofibromatosis. They'll have a skin, Caffouli spots, pigmented skin, hyposcoliosis. But very, very important, they'll ask you what other internal tumor they might have. MCQ, they'll ask you. You have to investigate such patients for acoustic neuroma or pheochromocytoma, because they are all developing from neuroectoderm. Then flexiform neurofibromatosis is quite common in the face. The face will be hanging. The skin will be hanging like that. That is common in the trigeminal nerve territory. Okay. Sometimes the whole leg will be like an elephant. Elephantiasis neurofibromatosa. In other words, whenever you have a big leg, swollen leg, then you have to tell it's a filariasis or lymphatic obstruction, okay, of various reasons, or it could be elephantiasis neurofibromatosa. So these are the three causes for a elephant-like leg, okay. And this is a Caffouli spot, multiple neurofibromatosis, as you can see, small, big, biggest nodules. The very important thing for you to understand is this particular picture to tell you that this is involving the schwannoma is involving the perineural tissue. So if there is a tumor, it is actually outside the main nerve. See, this is the nerve and it is stuck to the nerve. So you will be able to remove the schwannoma without any damage to the neighbor. There is nerve. So nerve can be spared. Sparing of the nerve is possible when you remove the schwannoma. Like that, schwannoma can sell out. Whereas neurofibroma, it is coming from the endoneurium. So you cannot remove completely without damage. So you have to cut to the nerve, especially if it is a peripheral small nerve, like a cutaneous nerve, you can sacrifice. But if it is ulnar nerve, median nerve, if you remove, then you have to consider a transposition. You have to put a nerve graft. So a neurofibroma cannot be a simple operation. It has to be done by a person like a plastic surgeon who, by removing this neurofibroma, he can do a bridge, the interposition, the nerve graft. Whereas schwannoma can be carefully enucleated. This is flexiform neurofibroma, schematic representation. Okay. Case number 4. What is case number 4? Who wants to tell? Somebody has to input. Bharat, would you like to see this patient? This is a 30-year-old boy came to us with a swelling for about 10 months, totally asymptomatic, but people, as wherever he goes, people are recognizing him for the swelling rather than himself. So no comorbidity. He is not on medication, but he wants to get it out of the way because it is unsightly to him. So examine and tell the inspection finding, Bharat.
Yes, sir. Sir, a hemispherical shaped swelling of size 3 into 3 centimeter in the center of the forehead, with the skin over the swelling structured and shiny.
Yes, good.
Is seems like erythematous.
Yeah.
Palpation findings, any sir?
No, palpative finding, I'll tell you. There's some more finding. Very important thing you should.
There's no absence of punctum. Hello, sir.
Say you should send just above the bridge of the nose. Okay, and it is 3 centimeter with a stretched skin, with no punctum, no dilated veins. Okay,
Yes, sir.
and there is no scar because any previous surgery, whether it's a recurrent swelling primary or on palpation, it is non-tender, it is not warm, it is cystic in consistency. Skin over the swelling is easy to pinch, and there is a mobility, is freely mobile in both direction. There is no evidence of any attachment, and there is no regional lymph nodes. What is the diagnosis?
Sir, dermoid.
Unless proved otherwise, any midline swelling. That's why that word is important. As soon as you tell the examiner, there is a line of embryological fusion in the ectoderm. It is dermoid as your first diagnosis, lipoma as a second diagnosis, sebaceous as a third diagnosis, and whatever other things like neurofibroma or anything else you can offer later. But these three things come automatically. So it is dermoid because of typical site. So there are few typical sites. Can you tell any other sites you have seen dermoid, or can you see?
Sir,
what is this here? What is this typical? It is a post-auricular. Here it is in the inner canthus. Okay, and this is the outer canthus. Okay, external angular dermoid, they say. Okay, it is outer canthus also. Around the eye also there is embryological fusion because skull bones are fusing here. So not only the midline like this, it can happen from head to foot anywhere in the midline. But in addition, it could be in the inner canthus, outer canthus, post-auricular. These are the three classical sites as far as the subcutaneous region is concerned. And there are some other areas also it is present, very typical, is pre-sacral. So you can see sacrococcygeal teratoma like that, pre-coccygeal. So pre-sacral, post-anal, retroperitoneal, sublingual. If you ask a patient to lift the tongue, it can be present. These are the classical sites, but we concentrate mainly on subcutaneous lump. Okay, that is what we are talking about. As I said, these are all the two different diagnoses. But one important thing, especially whenever you have a swelling in the head and especially in the midline, especially in a child when you have a dermoid cyst, an examiner will appreciate if you have this as a differential diagnosis, that is a meningocele, because meningocele is also behave like what you just now you said, but usually it is much more earlier birth, but because it has a communication through a defect in this skull bone, meningocele. Whereas dermoid cyst also can have the similar communication occasionally. That's why. So this is a dermoid cyst. I told you it is because of the entrapped ectoderm, because of embryological fusion line. And other dermoid cysts are called tubulodermoid cyst, like a thyroglossal cyst itself is actually a type of dermoid cyst only. Implantation dermoid, quite common in hairdressers. They have implantation of the all the hair, sometimes go in between, so they can come with a small cystic swelling in the finger or between the digits. That is called implantation dermoid. Or you have implantation dermoid in the scar tissue also. Last but not the least is a teratomatous dermoid. Okay, these are the four types of dermoid. The dermoid is having a completely lined by a stratified squamous epithelium, and it is having all the elements of the skin: hair follicle, sebaceous gland, sweat gland, and pultaceous material. That is a very important thing. Is it is not just epidermal contents; it is also dermal contents also present. And usually it's present in the subcutaneous plane, but rarely it can erode the bone also and go partly in the outside, partly inside. That's why whenever you have a dermoid in the scalp, or especially here, you have to do an X-ray or a CT. See, there is a dermoid cyst here with the erosion of the bone. See, this is a skull bone, and it extending here. And even if you have a 3D reconstruction, you can see a defect. That's why always you tell the examiner, you may be the only student telling this, and they'll appreciate that you know the clinical importance. Any dermoid cyst in the scalp, suspect meningomyelocele or meningocele in your differential diagnosis. You suspect erosion of the skull bone or extension inside as a dumbbell tumor. For that, you have to do a CT scan and a 3D reconstruction. The treatment is excision. Mostly it is subcutaneous. Very rarely, if it is extended like this, it needs neurosurgeon's input. Okay, this is this case number 4, I think, isn't it? 4 or 5. Let's see. So this is for who? Who wants to take? Let me have Sri Harshni. You would like to try? Or Raga Darshani, would you like to try? This is a lady, 60-year-old lady, presented to us with a 5 months history of a painless swelling in her forehead, and she is a diabetic. She is on oral anti-diabetic drugs. There is no other comorbidity. She is otherwise fit for her age, and she came, and this is her inspection finding, namely
3 into 4 centimeter sized swelling with the skin over the swelling hypopigmented with the hyperpigmented and edges.
good.
With the history of pain or painless, sir?
It is painless. It is painless.
Painless.
It is freely mobile. It is not attached to the underlying deeper structures, and it is feels little indurated, but raised margin. Raised, as you can see, wavy margin. It's a roll. When it is not everted, it is raised margin like this. Okay, and it is
Yes,
partly, as you say, it's partly pigmented. There is a little bit of scabbing or evidence of little healing also. So this is a very typical appearance of what lesion. Different diagnosis is basal cell carcinoma. So whenever you have an ulcerated lesion in the upper half of the face, above the imaginary line, stretching from the earlobe to the angle of the mouth, this region, when you have a lesion which has history of several months, and it is a flat lesion, ulcerated lesion with the margins having that raised margin, and the central area is having a little bit of like a scab or a little bit of partly healed or pigmented. Classically is a BCC or a rodent ulcer, because it is like a burrowing to the neighboring tissue. It is a locally invasive, no distal metastasis. Rarely only it goes to the lymph node, unlike a squamous cell carcinoma or a melanoma. Okay, so it is an ulcerative lesion in the upper half of the face. Very, very important. This should be your first diagnosis. This is one of the commonest benign tumor. Not benign tumor, it is a locally invasive tumor. Okay, it is neither benign nor malignant, borderline malignancy. Raised nodular pearly margin. I'll tell you, this is a very classical thing. It starts as, this is the common site, is the inner cancer. That's why it's otherwise called tear cancer, where the tears or tear drops get collected. Tear cancer, it is again called. And it becomes a nodular one, becomes a pearly white, like pearl, it's like a glittering. See, you can see here where I'm pointing, glittering, and it is nodularity with a central scabbing. And sometimes it becomes like a pigmented like this, giving you a different diagnosis whether it is a melanoma. Okay, and this is a very typical thing. This is the line. I don't think you need to know this line on Grant's line, but at least you should know that is an imaginary line. Okay, this is an imaginary line stretching from the ear lobule to the angle of the mouth. Above that line, if you have a lesion here, lesion here, lesion here, lesion here, if it is ulcerated, unless proved otherwise, first diagnosis for all of you from henceforth is BCC, because it is a locally invasive carcinoma from the basal layer of epidermis. What is basal layer of epidermis? You have to go back to a histology book. There are 5 layers of the epidermis: stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum or spicular cell layer, the stratum basal. And in the stratum basal, there may be areas where there may be some melanocytes, pigmented cells. So tumor from the stratum basal is basal cell carcinoma. From the melanocytes, malignant melanoma. From the stratum spinosum, you have the squamous cell carcinoma. So this is a very simple histological origin you should know. Okay. So that's about the diagnosis, and these are all the differential diagnosis. Here, because it's ulcerated lesion, there are a few things. Whenever you have a BCC, 2 things immediately you can tell: squamous cell carcinoma and melanoma. But there are a few more things, especially if it is a child, you can always tell, sir, looks like it could be an infected hemangioma. If it is a very elderly person, they can have what we call a seborrheic keratosis. That is because of the pigmented skin plaques, or keratoacanthoma. When you have a short history, 2 weeks, 3 weeks history only present, keratoacanthoma is something like a volcano-like lesion of 2 weeks duration, which is painful, and it is usually present in the upper half of the stomach. Keratoacanthoma. Okay, it is a squamous lesion again, but it is a benign lesion, unlike a BCC. So keratoacanthoma is a shorter. The BCC, usually the history runs in several months. These are all the features. Okay, what are the different types of basal cell carcinoma? If they ask you, you have to tell it starts as a nodule, ulcerative, becomes pigmented, then spreads like a field fire. Sometimes it will thick like a plaque, that is called morphic type, or spreads wider area even, that is called superficial type. So these are all the 6 broad category. Yes, basal cell carcinoma affecting the scalp is called turban tumor. Okay, turban tumor, Cox peculiar tumor. These are all the rare terms examiners very fond of. You have to tell us. Cox peculiar tumor is nothing but a ulcerated sebaceous cyst in the scalp. What is turban tumor? It is a BCC present in the scalp, giving you that appearance. Non-ulcerated BCC of the scalp. That is turban tumor. Histology. This is very important for prize exam. Even in MCQ, they'll keep you, because you have seeds of cell or nests of cells. The periphery of the cells are in a palisade pattern. See, they're all in an orderly, like in single file, they all stand, right? That palisadal arrangements. This is very, very typical of basal cell carcinoma. Okay, epithelial pearls, like onion pearls, very typical of squamous cell carcinoma. So the pearls are very, very important for all of you. Okay. What is the treatment? If they ask you, I will ask the patient, because it is locally invasive tumor. You have to excise this lesion with a 5 millimeter clearance. See, 5 millimeter clearance for BCC, 1 centimeter clearance for SCC, that is squamous cell carcinoma, 2.5 centimeter clearance for malignant melanoma. That is usually accepted for facial lesions. If it is elsewhere, you can even go for a higher, wider, but because you can't excise more than that, that's cosmetically not acceptable. So cosmetically acceptable margin. So if there is a lesion, this 1 centimeter, give another half centimeter all around, draw a line, then make an elliptical incision and excise and then close. You can't just make a circular incision and close. So this is something like a plastic surgery. Okay. So this is what we call 1:4 ratio. If there is a, if you draw this outer with a clearance, this is 1 centimeter, then you make another 3 centimeter, totally 4 centimeter wide incision, elliptical incision, 4 times this 1. So 1:4. Then if you close, you can close without tension. So all elliptical incision should have 1:4 principle. A 1 centimeter lesion will require a 4 centimeter ellipse in order to excise the lesion and close it without tension. That is a principle of plastic surgery. If it is not possible to close, what else you can do? You can put a graft taken from elsewhere, like a partial skin thickness, full thickness. But which is better? Full thickness. But even best would be a skin flap, local or skin flaps can be done. For example, this particular lesion, if you are excising like this, you can take the skin from the neighbor and you swing it here and cover this area. This is called a skin flap. Or if there is a lesion in the scalp like this, you excise this and rotate the whole skin like this and suture this area. So end it will look like this. This is called a Limburg flap or a rhomboid flap. This is a rhomboid flap. This is rotational flaps. So skin flaps are treatment for basal cell carcinoma. Rarely we use radiotherapy, especially if they are not very close to the bone or cartilage. Laser or cryotherapy can also be considered an elderly person who is not willing for surgery. 5-fluorouracil treatment can be also applied. So these are all some theory. If they are asking in a theory paper, you can write all those things. But in exam, they'll ask you, what is the treatment? Excision. How much clearance? 5 mm. How will you close the wound? Flap or a graft. You know any flap? Yes, sir. Name one flap. Limburg flap. What is Limburg flap? Rhomboid flap. Like that, you should keep telling. Automatically, the answer will ingrain in your brain. Okay. This is case number 6. This 45-year-old man came with a swelling, ulcerated lesion in the outer aspect of his left leg. He had burns several decades ago and he has been having scar. Lately, in the last 1 year, it ulcerated and gradually it developed what we call an indolent ulcer, painless ulcer, and it is keep on increasing in size. What you see now is after 1 year of persisting ulceration over the scar in his outer aspect, the left thigh, lateral to the knee joint, as you can see. What is a possible diagnosis? Dr. Romi, would you like to try? The diagnosis, I have given all the description. Under palpation, it is, as you can see, the inspection findings confirmed. The margins are raised. It is base is indurated. It is fixed. There is no mobility under the knee joint. Also, there is a restricted mobility because of the scarring. So, what could be the possible differential diagnosis or a diagnosis? It is a typical case of rodent ulcer. Sorry, not rodent ulcer. Marjolin's ulcer. Marjolin's ulcer is a low-grade squamous cell carcinoma. This is actually another typical case of a squamous cell carcinoma, which is common in our country, as you know, because of the tobacco chewing or also betel nut chewing. So she is having a large ulceroproliferative lesion with a destruction of the lateral half of the upper lip, angle of the lip, and lower lip, extending onto the cheek of size about 6 centimeter with a raised rolled out margin, indurated. Okay, with involving the lower alveolus, with the loss of teeth, edentulous patient, with the submandibular lymph nodes, hard in consistency, mobile. So like that, you need to tell about the tumor, node, and always tell the examiner, I will also do investigation for M staging also, that is metastasis, like X-ray chest, ultrasound, like that. So you have to think, whenever you think it is a malignancy, always think in your mind, TNM staging, what investigation examiner is going to ask you. This is another classical presentation or how a squamous cell carcinoma anywhere in our body will look like. A typical cauliflower, rolled out everted margin. It's like this, rolled out. A rolled out everted margin like this over the chest wall and near the breast. Because it is in the region of breast, not necessarily it is a breast cancer. It is a squamous cell carcinoma involving the skin. Okay. If you take a wedge biopsy is made what? Under local anesthesia. I remove a wedge of the tissue from the edge of the lesion, involving a bit of a normal skin and also the tumor tissue like this. Okay, so that way the pathology is able to tell what is normal, what is abnormal. Why this wedge biopsy is more important than the biopsy from the center? Because the central of the tumor, as you can notice even here, it will only contain necrotic tissue. It will not show the proper tumor tissue. So it will be giving you a false negative finding. So whenever a squamous cell carcinoma or any cancer for that matter, it is always advisable to take from the periphery, okay, where then it joining or nearby the next to the normal tissue. This is the classical. So raised rolled out margin, indurated base, look for the regional nodes. But a very important thing, all of you, because of the secondary infection, they may have a lymph node. So sometimes the examiner will ask you whether the node involvement is it secondary deposits or it is secondary to the infection of this ulcerated lesion, doctor. Then you have to tell the examiner. So the only way to prove is give them a course of antibiotics and see if the swelling is because of the infection, it will settle down. Second thing you can do is you can do an FNAC, fine needle aspiration cytology of the lymph node and see whether there's any malignant deposits inside. Otherwise, the regional lymph node enlargement per se is not sufficient to confirm it is a tumor deposit. That's what they will tell you. And I said already for BCC, here's for SCC, also the different diagnosis. Same keratoacantoma, seborrheic keratosis, amelanotic melanoma, basal cell carcinoma. One more thing I've added here is pyogenic granuloma. That is whenever you have a granulation tissue, excess granulation tissue in a infected ulcer, it can give rise to a protuberant granulation tissue that is called a pyogenic granuloma. Very common in fingers, in the umbilical region, things like that. Okay. And some back, because squamous cell carcinoma can come as a short, the important long case or even a essay also. So you better know everything about squamous cell carcinoma. It is from the stratum spinosum. That is prickle cell layer. There are Humpty number of precancerous or risk factors, starting from the sunlight, presence, as in this case, a Marjolain's ulcer is secondary to presence of a chronic ulcer like a varicose ulcer, sinus, scar, smoking, alcohol, chuta cancer, reverse smoking, like this man, how he is doing, and also heat. Like for example, this is a very typical picture. People in cold hemispheres or in Kashmir, for example, they keep a small pot of coal underneath their abdominal wall because of the warmth. So there they develop in the abdominal wall cancer. That is called cancri cancer of Kashmir. And radiotherapy also can give rise to cancer later. Carcinogens like cotton oil, chimney soup cancer, perceval pot cancer, that is called. And a human papilloma virus causing cancer of squamous cell carcinoma variety, or some other tumor or a lesion can becoming a squamous cell carcinoma. When you read branchial cyst, sebaceous cyst, I told you they can become a cancerous and they can become a squamous cell carcinoma. Under the common site of SCC, apart from the skin, oral cavity, oral cancer, penile cancer, carcinoma penis, carcinoma cervix, CA esophagus, CA anal canal. All this can be asked separately. For you, a carcinoma penis, oral cavity can be also kept in the examination. Be careful. But principally the same knowledge what you learned today may be useful. Like say, for example, they'll ask you, what are the precancerous lesion for squamous cancer? Because not from squamous epithelium, it becomes cancer one fine day. It becomes precancerous, like carcinoma in situ, then cancer, become invasive, then stage 2, there is to the node, then stage 4 to the distal metastasis. Like that only slowly it spreads. Local, regional, and distal metastasis. These are the different types of the lesion, precancerous lesion. One is a Bowen's disease, leukoplakia, white patches, especially in the oral cavity. Erythroplakia, red plaques, especially over the penis, glans penis, quite common before the penile cancer. Senile keratosis, pigmental lesion on the back of your elderly person. actinic keratosis because of the exposed area, sun exposed area, pigmented skin. Lupus vulgaris, tuberculosis. Xeroderma pigmentosum because of a absence of pigments in the skin. Burn scar like a Marjolin's ulcer. As I said, it can be like an ulcerative or proliferative, in situ invasive, epithelial pearls, very, very important histology. And Broder's classification, grade 1 to grade 4, depending upon the percentage of differentiated cells, grade 1 to grade 4, well differentiated to poorly differentiated. What are the two low grade tumor or tumor which are very slow growing tumor? If they ask you, you tell one is a Marjolin's ulcer, another is a verrucous squamous cell carcinoma. These are the two slow growing tumor. Okay. So to say it's a Marjolin's ulcer in this case, it is from the previous scar. It has been there for nearly a year. No pain, no regional lymph node. Because of fibrosis, there is no nodal spread, unlike squamous cell carcinoma or other types. Surgery is the only answer because it's not amenable for chemotherapy, radiotherapy like any other squamous cell cancer. Squamous cell cancer can be treated with radiotherapy like carcinoma, penis, cervix. We give us radiotherapy. Chemotherapy also some cases. What are the drugs? Bleomycin, 5-fluorouracil, cisplatin. These are the three drugs commonly used for squamous cell cancer. All those things are not effective for Marjolin's. So Marjolin's ulcer, you have to go widely excise that scar I showed you in this case. Give some skin cover. That is the thing. If the nodal spread is present in any patient, wait for 2 weeks. If they are persisting and FNAC is done, showed evidence of tumor deposits in the node, then you consider them for a lymph nodal block dissection. Like if the neck means modified neck dissection. If it is the inguinal gland block dissection like that. Axilla, axillary nodal dissection like CA breast. Okay, these are the various treatments. Now coming to the 7, 8, 9, we probably these are all very short cases. Quickly we'll go because I told you already. Leg ulcers we have already seen one of the chapters when we discussed. People who are not able to remember or joining late, you go back to the SEM master class on approach to leg ulcers, where we discuss various causes for leg ulcers, how to examine, treat a case of venous ulcer, arterial ulcer, diabetic ulcer, pressure sore like neuropathic ulcers, like trophic ulcers. All those things are given nicely in a 1 hour long lecture. So there you see, but here just a recollection. See, for example, this particular patient is having a 3 centimeter ulcerative lesion over the right lateral malleolus with the floor covered by unhealthy granulation tissue. The margins are it's a perpendicular margin, okay, and the surrounding skin is slightly hyperpigmented. And if they ask the patient to stand, the patient was having a dilated veins in the short subvenous system territory. So this is a short subvenous vein reflux, venous ulcer because of the refluxing short subvenous system. So like that, you need to make a diagnosis. So they'll ask you simple things like define an ulcer. You have to tell ulcer is nothing but a discontinuity in the or breach in the continuity in the skin or epithelium. If it is a mucosal surface, epithelium, like a duodenal ulcer, thing like that. If it is the skin, you say it's a breach in the continuity of the skin. Okay, it is excluding the trauma. So you can tell breach in the continuity of the skin because of the molecular death of the cells. Unlike in trauma where there is a traumatic necrosis. When there is an ulcer, the ulcer should heal by 3 processes. Very, very important. Wound healing in 3 lines. One is called wound contraction. The 1 centimeter lesion becomes half centimeter, quarter centimeter by the myofibroblast. Myofibroblast causes wound getting smaller and smaller in size. Second is presence of the granulation tissue, the velvety red colored carpet like tissue causing collagen deposition. That causes the granulation tissue, second phase of skinning. The third most important thing is the normal skin epithelium coming, epithelialization. So all the three should happen. If there is no epithelialization, the scar goes for repeated scabbing and ulceration, then it's why it causes Morgellons ulcer. So wound contraction, scarring, there is granulation and epithelialization. But all this can happen provided there are three important things are there. One, good blood supply, there is no infection, and there is no foreign body. Very, 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 very important point. They'll ask you. Presence of good blood supply, absence of infection, absence of foreign body will ensure any wound in our body heal without a problem. When you examine any ulcer, especially in the leg, look at the site. Here it is the gaiter area. Of course, size is obvious. Other things are SMS. I told you, SMS the details. You'll know the diagnosis, whether it is a venous ulcer, arterial ulcer, neuropathic ulcer, diabetic, vasculitic, traumatic, VAN, DVT, or malignant for that matter. I told you here, because of the typical the lipodermosclerosis, the hyperpigmented, thickened skin all around, location, and the way it looks with the dilated veins, very typical of venous ulcer. So SMS surface, whether it is pink like a granulation tissue, or white like infected tissue, or a yellowish like infected tissue, or it is a black like a necrotic tissue. There is surface. Margins, whether it is a raised, perpendicular like infected tissue, slopy margin like a healing tissue, everted rolled out margin like a squamous cell carcinoma or a malignant tissue. Surrounding skin, if it is pigmented like this, then it is very typical of venous hyperpigmentation, isn't it? So when you have any ulcer, you inspect, then you remember VAN. You have to examine that particular leg ulcer, venous problem. So examine for varicose vein stasis changes by asking the patient to stand. That is second step. Then you consider an arterial cause. So examine the patient's foot pulses. If a Doppler is there, Doppler pressure, ankle brachial index. Then it can be neuropathic ulcer if you think, especially if it is the sole of the foot. Then you have to examine for sensory loss, cotton wool, temperature, and all the 1 gram filament, 10 gram filament test. I told you all those things. You go and recollect. And all ulcers in the leg, regional lymph nodes you have to look for, especially if they are malignant ulcer, they will be positive. The last 2, 3 quickly. This also we have seen last class or the few classes before. A large swelling in a young patient underneath the left sternomastoid in the junction of the upper 1/3 and middle 2/3. Middle 1/3 is a large 7 centimeter swelling with the skin over the swelling normal, cystic in consistency, with the mobility all around, and it is less visible on putting the sternomastoid into contraction. How you make the sternomastoid contraction? Right sternomastoid is contracting when I start looking at the left side, or both sternomastoid can be put into contraction when I look down against my resistance, like that. So look down against resistance or look opposite side depending upon the which muscle you want to put into test. Then this particular patient, part of the swelling becomes less prominent because it is deeper to the sternomastoid. The finding and location like this is very typical of a branchial cleft cyst. Bronchial cyst usually happens around from the second branchial cleft. If it is first, usually it is more proximal, that is around the pinna. Third, lower down in the lower 1/3 of the neck. The typical location, what we see here, is because of the second branchial cyst, and they usually have a communication very often extending to the tonsillar fossa, very, very important. On their way, they have their course usually goes between the external carotid and the internal carotid. Very, very important. And they are very close to the important lower cranial nerve. So the proximity to the nerves, vessels should be understood before we take this case. So branchial cyst should not be taken as a simple operation. It has to be done under general anesthesia by an experienced surgeon. because of the risk of injury to major blood vessels and nerves in the neck. There are humpty number of cystic swelling in the neck, like here, as I said, apart from the branchial cyst, this case, these are all the other cases like dermoid cyst in the midline, ranula in the submental region, thyroglossal cyst with the movement of the tongue, and a lymph cyst or a cystic hygroma. Branchial cyst we excise, but you have to show that the tract goes between the external and internal carotid of tonsillar fossa, and it is closely going very close to the nerve number 9, 10, and 12. So these nerves should be guarded. Number 9, this case also we have seen before. A patient in his 30 came with a painful swelling in the right side of the neck for about 2 months, with the evening rise of temperature, anorexia, and weight loss. Diabetic patient. On clinical examination, he had a large 5 centimeter swelling in the right side of the face, right side of the neck. Skin over the swelling is hyperemic, reddish, stretched, shiny. There is no obvious punctum. There is no dilated veins. There is no impulse on coughing. There is no there is no pulsation seen. On palpation, it is warm. It is mildly tender, fluctuant, and skin over the swelling is pinchable, and mobility is restricted. There are some nearby firm nodes are present. They are about 1 to 2 centimeters with the evidence of mating, and there are lymph nodes palpable on the left side also, and both axilla. And examination, clinical examination at the end, my diagnosis is a cold abscess, because they can present as a lymph node, as a liquefaction, this cold abscess, and once the cold abscess ruptures, then it goes into various stages. The 6 stages of cold abscess or the tuberculosis is discrete node going for a mating, then cold abscess, deep to the fascia, then rupturing superficial to the deep fascia, cervical fascia, so that major component is deep and a small subcutaneous component like this. This is called the cholesterol abscess. And if that bursts also, then it becomes a sinus formation. Sinus is a blind track. Sinus and fistula, they'll ask you. What is a sinus? Sinus is a blind track. Give 2 classical examples. Tuberculous sinus. Number 2, osteomyelitis with a sinus to the bone. Okay. Pilonidal sinus is another classical example. This is already we have seen anti-tuberculosis treatment and everything. I'll skip that. We'll come to the last case quickly because the time is already there. This is a very typical elderly lady presenting with the swelling in the dorsum of the hand, and it is more prominent on position like this and less prominent on this. So stretching the joint like this, it becomes more prominent, and it is cystic in consistency, and mobility is also restricted in one direction. Very typical of a ganglion. So ganglion is any swelling which is well circumscribed, tensely cystic, with a restricted mobility. That is, a mobility is more on the along the tendon and across the tendon sheath and not along. Okay, and the mobility will be restricted on contraction of the muscle. So this is all the classical feature. So you have to say, so any swelling, especially around the wrist, around the ankle, or the dorsum of the foot, if you have that swelling, you have to keep one of the possible or probably the first diagnosis is a ganglion, because it is so common in that region. The other less common findings in that region are exostosis, a bone protuberance, synovial sheath tumor, implantation dermoid, neurofibroma, or sebaceous cyst. Very rare here, it can happen. This is a schematic representation of the ganglion. Okay, it is nothing but a mucoid degeneration of tendon sheath or a joint capsule. It usually has what we call a pseudopodia. So if you are going to remove the ganglion, you have to remove all this communication. Otherwise, recurrence is a rule than exception. If you excise this, there will be clear gelatinous fluid. Unlike other cysts where there is a watery fluid, here there is a jelly-like fluid. Okay, it is like a fluid helping for the friction of the joint or the tendon. So it is usually almost always pathognomic when it is present around the wrist joint and ankle joint. And this is the way we exercise. If the patient has symptomatic cyst, it has to be done under absolute blood loss operation. Tourniquet control, very important. Second, under regional anesthesia, you don't give local here. We have to give a, like if it is the upper arm, we need to give an axillary block or a brachial flexus block. So the whole arm has no sensation. Then you apply a tourniquet, raise the blood pressure to above the systolic. So there is no blood at all coming here. So if you make an incision, then it will be totally bloodless operation. You can remove the whole cyst without rupturing it along with all its pseudopodia. So recurrence can be minimized. So it is a very meticulous operation. Otherwise, those days we used to do, if there is a cyst like that, you break it by putting a heavy book on it, like a Bible therapy, we call it. That's not advocated anymore. Second is inject some sclerotherapeutic agent also is being tried. That also we don't advocate. Nowadays, if the patient is having symptoms, you do an X-ray, just make sure the surrounding neighboring joint is okay. Yeah, when in doubt, you always do an MRI. Then you go for the surgery. Okay. So, dear students, we have seen quite a few cases except melanoma. I think melanoma, I'll get a case next time. We have seen almost all cases. Thank you. Can anybody tell this young girl, 12-year-old girl presenting with 2 months, not 2 months, 2 years history of swelling, but for the last 2 months it's been painful. As you can see, she is quite comfortable. She is not troubled by this heavy swelling. It looks like another neck. Arun, what do you think is the most likely diagnosis?
Cystic hygroma.
Very classical cystic hygroma. It could be a large pedunculated lipoma. It can be anything. So this is a very typical of cystic hygroma. We can excise completely one of the common tumor which is having a brilliantly transillumination. I told you already the transillumination positive, transillumination negative. So that's the first thing. And this is very typical of Mohana. Would you like to see this elderly man like a spotter is growing something on his scalp?
Sebaceous horn.
Very nice. It's very rare specimen picture. Sebaceous horn, one of the rare complication of neglected sebaceous gland with the sebum extruding out. Good. This next one, what is it? This is a newborn. As you can see, just a 1 week old newborn with the right lateral chest wall. There is a swelling here. Sai Samhira, would you like to see this lesion? What could it be? A inborn lesion. Born. This
Any
lesion,
herniation, sir?
this actually is what we call a swelling, which is very soft, cystic, compressible. When I release my hand, it refills immediately. And there is a bruise present. Now you want to change your diagnosis.
Aneurysm?
It is a hemangioma. So hemangioma compressibility test. In other words, easily you can squeeze, empty it. When you take your hand, it refills. So emptying, as soon as your hand refills. The impulse on coughing should be present. That won't be present here. In a case of hernia, it will be impulse on coughing will be present. Aneurysm, it will be, if you put a hand, it will be pulsatile like that. Okay, this is actually very typical of the cavernous hemangioma. Large vessel hemangioma is cavernous hemangioma. Small vessel hemangioma is capillary hemangioma, like this one. Capillary hemangioma is quite common in a child, unless cavernous hemangioma, where people born with that disease from day one. A capillary hemangioma happens after a few months, like 7 months, 8 months after delivery. It remains there about 5 years, 6 years, then disappears. And they look like as if a strawberry is stuck on your scalp. That's why it's typically known as strawberry nevus. See, if you see a close-up, it looks like a surface of a strawberry, capillary hemangioma. This is another rare case where you have a patient with a fullness over the thenar eminence, and also there is a swelling in the volar aspect just above the wrist. And when I press here, the cystic swelling, you can feel the fluctuation here. That is called a cross fluctuation present. And this is very typical of what is the diagnosis. Anybody wants to give a diagnosis? Let us see. Any bright student here? Mohana, Bharat.
Sir,
cross
compound
fluctuation.
palmar ganglion.
Yes.
Compound palmar ganglion.
Very well done. Compound palmar ganglion. What is the cause for compound palmar ganglion? There are two common conditions. One, in our country, you consider tuberculosis. Okay, they usually have small melon seed caps inside. Second thing is rheumatoid arthritis. Rheumatoid arthritis or tuberculosis are the two common causes. This is the last case for today. This patient actually, when we did a colonoscopy, we saw a large lesion just underneath the mucosa in the bowel, submucosal lesion, which when I go and touch it, it becomes like a pillow sign. It is just yielding, slippery margin. Okay, so this is one of the classical example of submucosal. Mohana, would you like to see submucosal? Which one will be freely mobile submucosal?
Lipoma, sir.
Yes, it is a submucosal lipoma. What sign I was trying to describe is called a pillow sign. Like a pillow, when you press it with your head on the pillow, that area will become like a indentation, isn't it? That like that, if you the indentation over the swelling will remain whenever you prod that area, like a molding. So in the sign, so molding sign in sebaceous cyst, pillow sign in lipoma, pseudo fluctuation in lipoma, punctum in sebaceous cyst, midline in the dermoid cyst. Like that, there are some key points you never forget. That's a way to get clear understanding of the short cases and examine these patients with the confidence. I'm sure you will come out with the flying colors. So with that, I thank you all for having joined. We'll see you sometime, probably same time next week. Thank you. Bye-bye. Have the relaxing rest of the day. Bye.